Hello and welcome back to Explaining Acro. I'm Ben, and today we're joined by my friend, Dr. Nathan Hollister. He's been involved with a project called Circus in Medicine, which is kind of like doing some educational things for both circus people and medical people. And he's going to become a director of a program at UNLV pretty soon. And we're happy to have him on the channel where we're going to be talking about really all the different types of relationships that we might have with medical professionals, how we communicate in these different settings, and maybe get an idea of really what it's like in the medical world when you're starting to interact with people who are doing things that are physically a little bit out of the norm.
Absolutely. Thank you so much for having me. I'm happy to be here and answering these questions because it can be really, really confusing on both sides of the aisle of the acrobats or performers coming in and having no idea what the medical field's like. And then also for a lot of the medical professionals that it's honestly going to be the first time they're going to hear the words cord lease or the first time they're going to hear the word sear. And so hopefully this can help dispel a few misunderstandings that we both might have.
Yeah, absolutely. And just for a little bit of additional context too, like Nathan is always at the Circus Center doing trapeze, little tumbling, some trampoline and stuff like that, and is really heavily integrated into the circus community. So he just brings an awesome perspective that I'm happy to have him here to share with you. So to start off a little bit, can you talk a bit about just like as a doctor, like what your colleagues think about like circus and athletes and things like that?
Yeah, so a lot of it is like abject confusion. Like you're really lucky if you will find a doctor that understands gymnastics and being able to put things in gymnastics terms of like, hey, you know what a flip is. I do a flip, but I'm hanging by one arm and doing this. And so a lot of them too will understand in broad spectrum, the big productions. They'll understand Cirque, they'll understand Absinthe because for some reason they don't know the term Spiegel World. And so if you tell one of my colleagues like, you've seen the show Beatles Love and them jumping off a big wall. I do that. They'll be, oh, okay. But honestly, most of the time, unless you're using really descriptive terms of I'm on a big metal hoop that goes into the air, or I do like a rope, but I hold on to it, they're not really going to understand.
Yeah. So like they understand like, oh, like these are the main joints of the body and like this is what they do. But they don't necessarily understand the scale of like, hey, I'm like jumping onto a trampoline from like 12 feet in the air.
Absolutely. And they're not going to understand as much what it takes to do that.
Right.
Because most of the time in my world, what we worry about a lot of times, especially when it comes to injury, are ADLs or activities of daily living.
Right.
So those are kind of wash your hair, wipe your butt, feed yourself. And if you can do that, you're clear.
Right.
But our activities of daily living normally involve lifting other human beings above your head or doing a large number of flips before catching someone's hands. And that's what my daily living is. And so me just being able to reach here, but not get my arms back or get that pressure is not daily living for me. And that's something I have to explain to them.
Right.
And like in detail what it requires, because there's a lot of stuff that goes into trapeze, hand-to-hand, every different discipline that you don't see mainly. Like if you were to hurt your knee,
right,
I would be worried about, okay, well, do you have stairs in your house? Can you get upstairs? How are you going to get out of bed? Are you going to be able to walk to the store? But if I, being someone that knows circus a little bit, were to have you as a patient, my questions would then become more, okay, well, what leg's in front when you're basing?
Right.
What pressure do you have? What are you doing in your act? Are you going down into a splits holding someone? Because that's going to be really different how we have to rehab everything, what ligaments I'm looking at, and kind of even what chronic injuries you might have that started the problem in the first place.
Yeah, no, that's a really great point. So just like personally, I had a wrist surgery maybe about 2 years ago. And in terms of like activities of daily living, I was back in like 8 weeks. But in terms of just like, you know, my normal is I need to be able to hold a person on one hand. And that took maybe like 6-7 months before I could begin to approach it. And honestly, probably like 18 months before I felt like I was completely back to just like, you know, I can put like 140, 150 pound person on one hand.
Yeah. And it's one of the things where it's doctors understand the biomechanics under this. It's applying the biomechanics to the circus community. Because when you're talking about something like that and you're in an extremely unnatural wrist position most of the time. I've flown just a tiny bit of hand to hand. I am too small to base anything. But what happens is ligaments and kind of tendons in our wrist or anywhere on our body are, the way I kind of think about them is they're extremely moody and extremely Goldilocks. Of if you do not have the right amount of tension, and I'm using right really loosely here, it will, if it's too little, it's just not going to heal in a organized manner. Tendons like to be in straight lines and they like to line up, and they need tension to do that. So if I'm not doing enough, they'll heal disorganized, which is what we will largely say is similar to scar tissue or similar to like there being a knot there. If I put too much tension and I go fully, I just rip the tendon apart, which is a whole different set of issues.
Yeah, and like tendons in general too, my understanding is like, you know, a muscle recovers much, much faster than a tendon. And like making actual changes in like tendon strength and elasticity takes like, you know, orders of like 8-12 weeks. You obviously know that much better.
It takes so much longer because there's no blood to a tendon. So things need to heal. Things are really simple in the body. When things need to heal, they need materials to build it, and they need energy to make the construction happen. The materials get brought by the blood, the energy gets brought by oxygen in our bloodstream, and then a large biochemical pathway happens. But for you, a normal amount of tendon stretch on your wrist largely involves more than me because you're going to have a normal person. So if we're doing normal rehab for someone that's not a wrist intensive person, it's of course going to heal slower because we're not putting the appropriate amount of tension and the appropriate amount of force direction for your wrist and what your wrist is going to do. And so it becomes a really difficult question when the doctors know that biochemistry really well and know what it takes to heal, but have a hard time applying that to the end result that you want to get.
Absolutely. As just, you know, say an acrobat who's dealing with like nagging pain and injury and things like that, are there like, you know, guidelines you'd have in terms of like activity modification, like kind of initial treatment? When should you start seeking medical advice? And
so it's really hard because almost everyone's going to be a case by case basis because weird things can happen. But if I was speaking on the most general level, what I always say is acrobats and people that use their bodies like professionally or at a very, very high level are very, very in tune with their bodies.
Absolutely.
We have an idea of what soreness feels like and that kind of dull ache. And we also know what the feeling of, I really overdid legs and now I'm trying to like walk upstairs. But it's still that same quality. It's still that same soreness, dull, achy feeling. I start to get really worried when I feel sharp. So when I start to feel pain that ramps up very quickly to a maximal intensity. So if I were to reach above my head and I'm just like, oh, this is getting worse, worse, worse. Oh, that's super achy. More normal, not as concerned. If I reach up, I'm fine, fine, fine. And I hit a point and it's just instant sharp and I'm pulling my hand back. That starts to worry me more. The thing that I would counsel though is that does not mean all the time that something is torn. So many people will come up and be like, I have this really sharp pain, I tore my pec. I have this really sharp pain, I tore a ligament in my ankle. It's not all the time. You can have really bad muscle tension of muscles just being super cramped. And when they get cramped to a point, they can get cramped to a point where it cuts off blood flow to the muscle itself. Not completely, the muscle's not dying and necrosing, but it's cutting off enough blood flow that you're not getting any of that lactic acid out. You're not getting any of that other stuff out. And you're reaching to a point where it doesn't want to even be stretched because it's just pissed off. And you can get that sharp pain.
For sure. Or things like nerve entrapment.
Nerve entrapment, absolutely. Or even like the start, like a lot of time, I have an ultrasound at Circus Center. So sometimes the biggest thing people worry about is, oh my God, did I tear something? And yes, you can have chronic slow tears. I get more worried if someone like had a bad fall and now they instantly have sharp pain. That worries me more than, yeah, no, I've been training my act more and it's slowly getting worse. Can that still be a chronic tear? 100%. But we like to look, and if we have an ultrasound because Circus Center so graciously bought an ultrasound that we can use there. Let's take a look. But I'm not even able to see very, very small grades because they're so small. And that's how our body heals and gets stronger anyways.
Right.
But when you do start to have those bigger tears, that's when it becomes hyper specific on the individual and the type of tear. It's depending on where the muscle is on your body. Pec tears are normally worse. Bicep tears, if you can physically see them, get bad.
Oh, yeah.
And that's when we start to have questions of, well, what are the options? And a lot of the options early on are, well, we're going to do a whole lot of rest. Are we normally doing a little more rest than we need to? Probably. Can you train around a tear? So yes, I have a tear in my bicep, so I'm going to stay home and do nothing. It's like, no, you can do legs, you can do core, you can do other things.
Right.
You just need to be careful about this one specific muscle. And again, if I'm an ER doc or if I'm a general doc in the public and I'm telling someone that never uses their body in any significant way in the public, don't use your teres minor. They're going to have no idea, one, what I'm talking about, or two, how to do that.
Yeah.
If I tell you, hey, don't use your teres minor, you might still do it anyways because you want to, but
I know what it is.
But you'll at least know what you could do to stop doing that.
Right.
And you can even know there might be some positions that are fine. Like one example is I had a friend who had a tear of a ligament in their knee and was trying to figure out something to do. And they were asking, well, can I do handstands? And the either physician assistant or nurse practitioner at their orthopedic office was like, oh, absolutely not. What if you came down or lost control and landed only on that bad knee? I'm like, yes, that is a risk. That would be very bad. But if you've been a hand balancer and do a bunch of handstands, I'll tell you, if you come down on that knee, you're screwed and that knee's going to be really bad. But if you come down normally on the other one, you can do handstands all you want. You don't need pressure on your knee for a handstand necessarily.
Yeah. So it's like, if you're a hand balancer, you could evaluate case by case. It's not a good time to start doing handstands.
Correct. Yeah. It would not be hey, I'm super unsteady and I fall on my back half the time. Yeah, no, let's not start doing that. But there's also options. And the other thing that I personally love about the circus community is the amount of cross training that happens, the amount of times that you see a tumbler going and trying partner acro, or you see a trapeze artist going and doing flatbed tramp. It could be an okay time to do that. If you're a trapeze artist with a shoulder injury, you can do a lot of trampoline with your shoulders still in tow. One of, I think, our mutual friends, Scott McDonald, is very famous for having an injury and learning his twisting with his hands in his pockets because he couldn't lift his hands a certain amount. There's so much room to still do what you love. Because the other thing that, again, where's the hard data on this? It's hard to find, but attitude towards injury does make a difference.
Oh, huge.
And if you're asking someone who their life is doing all of this stuff to not do any of that stuff anymore, you're not in that training area you normally were, you're not with your friends that are in that training area, that's just going to make anyone depressed. So it's finding the things that people can do is going to be important. So going back to what advice would I give generally is I would ask what the limitations are, not necessarily what can I do. And yes, there might be room to ask what can I do, but asking where are my hard stops? Where are the I absolutely cannot? Because to be fair, sometimes medical professionals will push the line of what you can't do to be a little more restrictive to be safe.
Right.
But really asking what are the things that will make this worse?
Right. So landing on this leg, loading it in this particular way, and getting kind of the biomechanical understanding of what you want to be avoiding.
Correct. And then it's the being safe about it, understanding that there are lines and some lines are hard stop. If I have torn ligaments in my knee, even then, technically, they all stabilize different areas. I have lateral flexion, medial or towards the middle flexion, anterior forward, posterior backwards, and each of the tendons kind of help stabilize one of those areas. technically the other tendons are in place. Would I play with that? Absolutely not, because all of the tendons are intact in your body as a unit. But understanding, hey, the really bad thing is if your knee bows inward while the rest of your body bows outward.
Right.
Even that understanding, if you have a mistake, if you have a bad step at home, if you fall a little bit getting out of the shower, you might notice your knee moving in a certain way and you're like, I messed up. That gives you a little bit of peace of mind of, well, this isn't good. I know this isn't good at baseline, but it didn't move this way.
Yeah.
It might not be as bad. Or if it did move that way and now your knee's the size of cantaloupe, you know, I better call my orthopedic surgeon or I better call someone.
Yeah. One of the things that I've always been kind of interested in, so I have a background in like powerlifting and strength sports where like kind of fatigue management, deloading, and peaking are like kind of top of mind things. And in Circus, I definitely see a tendency of just train all day, every day, deload, what's that? Just in the context of like, I think general good training practices, but also like, hey, this is starting to bother me a little bit. Like, what are your thoughts on that kind of like fatigue management through like basically modulating, frequency and intensity, like any of those variables?
Yeah, so it gets hard, especially in Circus, because me specifically will be like, I'm using so much of my body. This isn't like me doing biceps every day and getting really fatigued in one specific muscle. It's like, man, no, I'm using everything. I'm using my rhomboids, my traps, my glutes, my hamstrings. So it's like a full body workout. I can keep doing that. The issue a lot of times with fatigue, one, you do have those small chronic injuries they can happen in perfect alignment, but a lot of the times the best we try, we might not have perfect joint and body alignment in what we're doing. If you think of especially those really fast moving dynamic motions in Circus, again, being a trapeze artist, the biggest thing I think about is my break. When you're holding your feet up, going down, 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 and then slamming your feet backwards as hard as you can. It matters significantly how my shoulders are. Are my scapulas flat against my rib cage? Is my shoulders engaged up, down? Where is it? How am I pushing back? Am I thinking about any of that when I fly? Absolutely not. So if I just happen to be in a poor position and I have a lot of muscle fibers and everything that goes right under two bones, the top of my scapula coming here and my collarbone going across and here. If I'm slightly in a wrong alignment or I'm putting a little bit too much pressure, the bone is just a saw.
Yeah.
And it's just going over that muscle over and over. And that's how we can get the chronic injuries that might be due to malalignment, or sometimes the skill's just a beast of a skill. And it's like, I don't know if you have a gymnastics background, but we had like the double backflip on rings that you come around that you're like, I trained that before a competition because that skill just hurts your shoulders.
Right.
So one thing that I would be very careful about is like, is there one specific part of your body that's getting really sore? Is this just I'm tired? Or is this like, no, this is just my normal shoulder pain that happens every time after I do one arms? It's like, well, maybe let's look at what's going on with your shoulder, and are you like slowly creating a micro thing?
Right.
The other thing with fatigue to talk about is the other times that circus people and performers in general get injured outside of those chronic, slowly over time injuries is when something goes wrong.
Yeah.
And the more tired you are, the more prone, no matter how good you are, the more prone you are to making a mistake or making something happen. And that's where I think it gets really difficult, because there is no line. There is no line of this is the point where I'm too tired and I just can't go on. There is, but no one's hopefully going to be getting there and pushing through that all the time. So you gotta weigh the risks and benefits. And I think a lot of time in performance, we just think, I can get just one more rep. I can get one more rep. I can do one more of this. It's gonna, I need the numbers. It's like, well, you need good numbers.
Yeah.
And so being mentally cognizant and kind of that responsible to yourself of, am I really going to get more out of this one more rep than the risk of something going wrong? And the risk is low a lot of the times. We mostly know what we're doing, but it's not zero.
Yeah, I mean, particularly trapeze, right? You can like have a one-arm catch unexpectedly coming out of rotation, and like that can...
I had one of those. They suck. They don't feel good. But even think tramp wall. Like the amount of passive meaning you're not thinking about it, flexion you have to do in the tramp bed.
Right.
Of like, it's me and Scott and some people are even trying to like study like exactly what muscles are flexed, because it's so ingrained in us that when you're tired, your mind and your body aren't talking as fast together. So are you more prone to get whiplash, concussion-like studies or concussion-like symptoms?
Yeah.
And then another thing that throws a whole nother variable into it that people should be aware of is the peer pressure. What happens if you're not a solo act? What if you, like for you are holding someone else above your head? If you're like, I only slept 3 hours really, and I've been training every day for the past 4 weeks, and you're like, let's work this new hard skill I've never done before, now becomes the one, I don't want to let my partner down because we're training together. They can't train without me. This is an essentially duo thing. But being able to really take an honest inventory of where am I? Rest isn't the worst thing. Like I talked about tendons and ligaments earlier, everything in your body heals under the right amount of stress.
Yeah.
And there is too much stress. And so there is a point of the rest is not doing nothing. That is when you are getting stronger. That is when you are getting nutrients back to your musculature, your ligaments, everything like that. And so it's like there is a benefit in resting.
For sure. Yeah. And want to move on from the topic, but the other thing I just observed too is certainly the professional levels, like you're doing like 48, 50 weeks out of the year. And like even like the recreational community, like there isn't this kind of like built-in off season that you might have with like traditional team sports or strength sports or stuff like that. Like it is just this kind of like continuous.
And it's really
thing.
Interesting in the recreational space too, because like even in medicine, I only know it in medicine, it might be everywhere else. We have the term like a weekend warrior.
Yeah.
When it comes to injuries, which is the person, and it's like the classic one that I always tell the story of like working marathons and stuff like that, is the person that has not trained at all and then decides one weekend that they're going to run a marathon or something like that. And you will just see them hit walls at really weird parts because they're bringing their body from 0 to 100.
Yeah.
And they'll be doing their desk job or whatever during the week, train really hard on the weekend because they're like, this is the only time I have to do this. I'm going to go balls to the wall on the weekend. And then you can get these injuries or these chronic things because, again, when you're getting fatigued, like when you're not used to that, you're more prone to not only acute injuries, but your chronic injuries.
Right. Yeah. It's important to have that like tissue tolerance as well as volume tolerance. And that's built up very slowly over time. And like particularly in the context of like a lot of what we do, we want to have tissue tolerance that is like well in excess of what we're doing because like happy path, like everything's good. But, you know, like someone's falling, you catch something with only one arm, you come down a little bit off. Like you want to have that like margin of error. Yeah,
absolutely. Because you want to be able to not only do the skill safely, you want to have enough energy and reserve to save yourself safely. Which is another big thing because it's going to take way more energy to save yourself than it is just to do the trick.
Yeah. So in the context of like, hey, like something has gone wrong and now we're in like we have a serious injury, maybe even an emergency medicine situation or stuff like that. What are some things that, like acrobats and athletes can do in order to like advocate for themselves and like really communicate effectively to the doctor? And as a doctor, like what are the things that you are kind of looking for, the types of questions that you'd like to answer, and like your at least perception of like what your colleagues may be doing in these contexts?
Yeah. So I think whenever an injury occurs or something has happened and something seems wrong, there's kind of 3 levels that you can kind of hit of like how wrong is this. There's the PCP, primary care physician level.
Right.
There's an urgent care level, and there's an emergency medicine level. Me being an emergency medicine doc, I still see all 3. People will come in with PCP, primary care level complaints. And so what the biggest thing you can do coming to any of those levels is if you have a video of what happened, or if you have a video of the skill that you were trying to do, even if it's not you doing it, that is amazingly helpful. It's amazingly helpful for the doctor to be able to see what exactly is happening and you being able to explain what went wrong, but also where it hurt One of the things that I've seen some of my colleagues do, or even just friends who don't practice that discipline, is you'll see a video and you're like, yeah, you got hurt there. And they're like, no, it hurt here later. And you're like, oh, I see it now that you say it. So really dictate the video to them. Commentate. I was doing this. I was feeling a little fatigued in this area. I went down for the coin in my sear wheel, and then I felt my right pec here. Or I was doing the hand-to-hand. We were a little unbalanced here. And the doctor's probably gonna be like, you don't look unbalanced at all. Look, you're not even moving that much. And you're like, I was literally fighting for my life this whole time.
Yeah.
Then we finally broke here. I landed here. It hurts here. And then you can point on your body afterwards in context of that video. The other thing that's going to be really important is knowing what to expect from every level, because every injury is going to need.
Yeah, and just to pause on that,
please.
like you have the video that like kind of shows a clear mechanism of injury. If you're in a context where there isn't a video, like what can you do to communicate both the like severity of like, hey, this was like, I fell from this high on this body part, as you know, how can you help in that context?
Pull up a video of someone else doing that skill. Like pull up YouTube. Because like, again, some of the big things of like, we've had people come into the trauma centers and my nurses have told me, don't worry, they fell off a swing. And I'm like, wait a second, what
type of swing?
Oh no, what type of swing? Like, I don't know, like a Russian swing. I was like, oh God, no. And pulling up, I literally pulled up, Russian swing, showed it to them, and they're like, oh no, we get it now. But it's like, I didn't have the video of what happened.
And for context, that's like the difference between like a swing set and like falling off a, like 4-story building?
Yeah, it's like 20, 30 feet.
Yeah.
But it would be also the idea of like, in Acro, like someone saying that I fell from the top of a 3 high. And it's like, people will kind of know like, oh, you were standing on 2 people's shoulders. But like, when you see it, you're like, oh no, that is different. And you aren't falling normal because someone has been holding your feet.
Right.
So it's like they're having context, having some form of video that they know at least what realm we're talking about is going to be the important thing. Because we will even try, like, even when we talk across disciplines, like, it's hard for us to put forward everything that we're feeling and everything that's happening. I learn stuff daily about different apparatuses that's like, oh, your arms must be so strong because you do this. And they're like, actually, it's all my legs. And you're like, oh no, I've completely misunderstood this discipline. And we speak the same language.
Yeah.
Now imagine someone that does not speak any of our language, and even subconsciously, we're going to be using terms of like, they might not even know what a one arm is. And they're like, what happened? Did you have an accident? What happened to the other arm? It looks like you have 2 arms right now. And you're like, no, it's this. And they're like, oh, I have no idea how to do a normal handstand. So I have no idea what goes into shoulder stability of one arm. So I think, yes, you can describe it while you're getting the video and everything ready, but videos speak 1,000 words.
Awesome.
Especially in the medical setting. And then going to what would be really helpful for acrobats going in to these situations where you're like, something's wrong. Because I think a lot of times what I hear people feel is, I went to the ER and they did nothing. I went to urgent care and they did nothing. Sometimes that's true, and some of my colleagues aren't great and are under the assumption of a lot of litigation and a lot of like, if I do too much, I don't want to get sued for this. I don't understand this. In the ER, our mindset is always life, limb, eyesight, life, limb injury. And so I'm looking for things that would threaten your body in a way that I would need to intervene within minutes to hours.
Yeah.
There are some of those. Some of the things that I would worry most from the acro community coming in, that's a like, make sure that you describe this, is any large head strikes where there's vomiting involved, the head looks deformed, pupils look weird. It wouldn't be uncommon though to come in, and I would not expect a CAT scan of your head right away, but that is at least be evaluated, because we have ways, vital signs, physical exam to rule in and out kind of brain bleeds. Without that, I would be really worried about any fall on an outstretched hand, call them fooshes, just because those are ones that it's like, I need to follow closely. with certain bones, small bones in the wrist. If you break them and you don't get surgery, fixation, something, the bone will die. Like the bone will necrose and die, specifically kind of your scaphoid. Those are big things where it's like, you're probably going to expect either a thorough physical exam, some imaging of some kind. So it's like the big types of scary injuries. So again, that's kind of like head strike, loss of consciousness, vomiting, greater than 30 minutes of amnesia, full zone outstretched hands with tenderness, specifically in kind of the snuff box area of the hand here. Anything with large chest pain, anything where you see a bone sticking out or a joint kind of where it's not supposed to be. Inability to move past certain ranges of motion. There are certain things where it's just like, no, I can't raise it more than this because it hurts. There's another thing to be like, it doesn't go. Like I can take the pain and I just can't, like you can push it and it doesn't go. Those are all kind of like scary things. And there's more to be like, no, you should really go and see a doctor, because some of those, like we were talking about the scaphoid, was certain finger fractures or kind of these smaller bones. There's so many small tendons and stuff that you can get permanent deformities with certain ruptures of tendons or bones that we would tell on physical exam, not imaging, but that might need not surgery, but splinting. There's specifically some swan finger deformities and finger deformities of the finger itself where all I need to do is keep you in a splint and it will heal just fine. But again, those are the conversations to have with the doctor of, this is a splint that do not take it off. If you take it off for 1 second, it's going to ruin the tendon and it's not going to heal right. There's other splints, like I broke my collarbone and I'm having it in a sling that's like, yeah, if you take it out for a second, it's gonna be okay. But that's the reasons to ask again, those hard stops. What are my hard stops of I definitely cannot do this.
Right. But like that emergency context, it's like you're doing high level triage of like what's really, really bad. And other than that, you're probably trying to set up some kind of like, x-ray so that the MRI later can be handled by insurance, or give like kind of clear next steps for care.
And get you to the person that's going to fundamentally do that. Like fix this, or try to fix it. Because in the ER, even if you come back again, you're not going to see the same doctor. If you do, you're really lucky because they don't work that many days a month. But they need to get you someone who can follow this over time. And again, with a lot of people that might be worried about like, I can't afford surgery, I can't afford anything like this. It's getting you to whoever can help you navigate this. Is this an orthopedic surgeon to talk about non-surgical options? Is this a physical therapist to talk about exercises that you can do to kind of get the muscles around this stronger to support it? It's getting you to where do you need to be health-wise? Or at the very least, know what your options are. Know what options are available to you to get. But that being said, if it is something that feels not emergent, and this is coming from a dude that waited 24 hours to go to the ER with like a bone almost sticking through my foot. When I broke my foot, I will push things the other way. Try and go to a primary care, just because, not because the ER doesn't want to see you. I actually love it when I get MSK injuries and I can do something about it, but because they will be the ones that are ordering it and following up on it and sending you to the next person. So they're already someone that needs to be part of every part of this process, and you're just getting them involved right away. I very much understand if you can't make the appointment. Yes, now you're looking at more urgent care versus ER, which, I mean, I guess we didn't really talk about, but urgent cares, if you're going to go and see an urgent care and you think it's an orthopedic issue, a bone issue, a muscle issue, you can always call and make sure that they have an x-ray. If you go to an urgent care that's a small urgent care and they don't have an x-ray, you're going to go there, you're going to pay your copay, and they're going to say, go to the ER because we don't have an x-ray. But I mean, I broke my foot twice and I got both of them diagnosed in urgent care. And I got the x-ray at the urgent care, I got the cast, and I got sent to my orthopedic surgeon. ERs, you are probably going to be dealing with a higher copay. Most of the time, even if you have great insurance, most of the time you're looking at $500 just to kind of walk in the door there, where urgent cares, you're generally looking at double-digit, not triple-digit amounts. Some of you might have amazing insurance, and that would be awesome. But generally, urgent care is going to be a cheaper option. The one things that I would warn people, if you have had that massive head strike, if you fall off something really high, if you fall off a 3 high directly onto your head, please don't go to the urgent care. Go directly to an ER. If you have a bone sticking out of your body, go to the ER. If you have something that is obviously dislocated, which doesn't mean, oh, I feel a bump and it feels a little bit weird. It's my shoulder's down here now and my shoulder used to be up here, or my wrist is out and droopy and I can't move it. The urgent care will send you directly to the ER anyways, because we need to get that back in socket now. And last thing that's just please, if you ever have an injury and farther out from your core, so what we say distal, if I hurt my elbow and I feel numbness, tingling, or weakness in my hand, those are all go to an ER. Do not wait. Don't be a Nate and wait 2 days to do it, because that's kind of signs that there might be nerve damage. There might be something, and nerves will die, and you are at risk for some permanent injuries there. So any nervy-like symptoms, motor sensation, anything like that, distal to an injury, don't pass go, don't collect $200. Just come to the ER. We'll take care of you right away.
Absolutely. And so a couple things. So in the context of, circus things, unfortunately, like head injuries and things like that do happen. And I can think of a couple that I've been near where, the individual isn't necessarily in a state where they're capable of like self-advocacy, or like the first responders are like, this person hit their head, but they're, not taking the board or whatever. And you need to do some advocacy on the behalf of people. Like as a friend, as an onlooker, do you have any advice in terms of like ensuring they get proper care? Or I've like seen a case where someone comes down for an extended hand on the head. She's kind of can't talk. And the emergency room is initially like, oh, she like just fell on her head from a handstand. It's like, no, she fell on her head basically from the top of a ladder. And like, what are your thoughts on just like that kind of like taking care of people?
Head injuries specifically, and kind of advocating for other people that can't advocate for themselves. One, if anyone is ever in a position where they can't advocate for themselves, something is probably very wrong. And so being able to go either with them, sometimes ambulances are super nice and will let you go with them. Other times just asking, what hospital are you going to? And having that person's name and date of birth available to you. Because if you go in to check in and you're asking for someone, that's the two pieces of identifying information that the ER is going to ask for you. Like, who are you coming to see? What is their date of birth? One of them is to show, hey, can I find them? Are they here? And the date of birth is to be like, is this person legit? Do they know this person? And you can also explain like, hey, I was there when the accident happened. I would like to provide collateral information. Again, videos are super helpful. Being able to explain it is super helpful. But speaking specifically of head injuries in these iffy situations, again, if you have a medical professional there, if you have a trainer there, a physician there, someone there, we have a very, very specific set of rules that we normally look at for head and neck injuries. And they're called the Canadian Head CT rules and the Nexus Neck Criteria rules. But I would not advocate that anyone try to use these if they're not a medical professional, but just so you know what's kind of going through our heads is the biggest things we look at is age is going to be a really big determinant. If you're under 16 to over 16, it's going to change our algorithm a little bit. I look at what is your GCS, which is Glasgow Coma Scale, which is basically a fancy medical term for how awake are you. I look at, are you opening your eyes spontaneously? Do I have to say, hey, 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 and you open your eyes? Do I have to provide a noxious stimuli or pain and you open your eyes, or are you just not opening your eyes? Are you talking to me? Are you saying gibberish? Are you not saying anything at all? How's your vocality? How are you speaking? And then motor. Like, are you able to follow command? That's why you'll hear, if you see the medics come up, give me a thumbs up, give me a thumbs up. We're looking, are you following commands? And then if you're not, I start pushing on your nail. I start doing these things to see, do you withdraw from pain? Do you bat my hand away? How conscious are you? So if someone has an unchanged GCS, the perfect score, your eyes are open, you're talking to me, you're making sense, that's a good sign. Then I start looking, is there any signs of you have a skull fracture? Like, oh, there's a big dent in your head there. Or I see a bunch of blood coming out? Or is there any signs that I'm palpating and I think something's broken? Instant CT, do not pass go, do not click $200. I look for signs of what's called a basilar skull fracture, or the base of your skull, which can happen a lot, especially when people are landing on their face, landing at these weird angles. So I look for heavy bruising around the eye. I look for any blood in the ears. I look for any brain fluid coming from the nose, which would be like this white, super clear liquid coming from the nose. And then I look. Most people that have a concussion or a bad concussion with a fall like that will have some amount of retrograde amnesia, which means they will be forgetful about the event. They will be very, very repetitive. So one of the most common things that you'll hear them ask the same question over and over and over, like within seconds of it. Like, oh my gosh, what happened? Oh, you fell out of a high hand. Oh, gotcha. But what happened? I literally told you 3 seconds ago. That can be normal in concussions. That's not always. So I see a lot of people being like, they need a scan right now. Not always. The biggest thing that we're looking for, because I think the biggest misconception is people say, I need a CT scan because I need to see if I have a concussion. Right. Not how CT scans work. A CT scan is only looking for a broken skull, any broken bones really, and blood. So we're looking for either hematomas, which is you have a blood bubble forming in your skull, or we're looking for kind of just blood just diffusely in the brain. Those are kind of like neurosurgical emergencies. We will either be doing surgery, we'll be keeping you in the ICU to watch you very carefully, we'll be watching you in the ER, we'll be doing something to observe you for the bleed. A concussion is a clinical diagnosis, meaning I don't need any imaging to diagnose you with it. So with that, you can have varying levels of concussions. Concussion just means bruise on the brain, because the brain's kind of a jello-y sack that sits in a bunch of fluid that sits in a skull. And you shake the skull around and the brain goes bam, 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 bam. So you'll get these injuries called the front hit and the back hit injuries. Those can be really bad, but if I'm seeing blood, I'm seeing some signs of swelling around the brain. So those are those hard, besides kind of what we said before of like you're altered and you're not making sense, or you have a very obvious skull fracture. Everything else I'm looking for is kind of, is there a sign of swelling of the brain? Yeah. Something pushing. That's irretractable vomiting, meaning you're vomiting and not stopping. That's your pupils are different sizes because your brain's pushing on one of the nerves. It's making it so that they can't dilate or contract. Or I'm looking for any other, you can have weird micro changes, which is why medical professionals need to do this.
Yeah, and there's been a couple high-profile incidents too in the Acro community where it was actually like broken cervical vertebrae.
Yeah.
Like, are there specific like considerations or risks for those?
Yeah. So risks are always, so again, they can happen with anything, but specific risks are hyperflexion or extension at the neck. So if you're landing and you're hyperflexing your neck this way, or you're hyperextended and you're extending your neck this way, cervical fractures specifically are very different. There's basically two kinds. There's stable and unstable.
Right.
Unstable means I'm keeping this collar I put on you on. No, you can't take it off. Yes, I know it's very uncomfortable. And we're going to get surgery because I have to put something in to fixate this, because whatever is broken, and they're all weird different names, teardrop fracture, Jefferson fracture, burst fracture. They're all weird names. And so you might hear these, but it's something in the bony spinal column has become uneven that if the neck shifts too much, it can put pressure on the cord.
Right.
So that is why they're going to put the neck brace on right away. Good signs are if you're not having any pain with palpation or touching the actual bony parts. And one of the things I can definitely say, if you are ever at worry for this and people will be touching your neck, the question is always, is there pain on the bone? Your muscles will hurt like heck. You just fell and landed on your head. We're looking specifically for bony fracture, bony tenderness because of exactly that. We're looking for the fracture. The other thing we worry about is neck goes to kind of the shawl distribution. If you were to be wearing a long scarf, that's where the kind of distribution of the cervical vertebrae go. So I start to worry about numbness or tingling down the arms, inability to have a grip strength, anything like that. But one thing that I can say for people that might undergo a neck injury and be freaking out, this is not always indicative that something is permanently wrong. What can happen a lot is just like you can bruise a muscle, a joint, a bone, anything like that. You can bruise your spinal column and it can swell and it can push against the bones. When that swelling goes down, the function can return. But that being said, if you are feeling anything in your hands, that is don't move. Stay very still. We need to get a C-collar on to kind of help prevent any further damage.
Yeah. So kind of like trying to put all this together into like some kind of recommendation we can give. So like either as, someone who just fell on my head, or say an onlooker at like an Acro jam, or maybe a gym that doesn't have like medical professionals on staff or something like that. Someone's just fallen from their head, let's say from like a hand-to-hand or something like that. Height of like, let's say like 4 to 6 feet. Like what are the steps you should take in order to like get this person care?
Yeah. So, I mean, the first thing would be don't move. Don't try and sit up. Those are the like definite things that can be problematic. And then really let the person dictate it, because it's not going to be a lot that you're going to be able to see from the outside.
Right.
And just let them know, do you have any numbness or tingling in your hands? Do you have any neurological symptoms? And I would definitely say it's going to be a case-by-case basis for a lot of these people, but generally if the person's like, I'm completely okay, like I'm a little sore, I'm a little dazed, nothing hurts, nothing's here, be like, okay, I would take some time, make sure nothing develops, but I'm not going to like force you stay on the ground, don't move, I'm going to do this.
Right.
If again, they're altered in any way, if they're having any of these neurosymptoms, anything like that, I would definitely say, hey, we should definitely consider calling medical professionals to come over. Good ambulances can always do that triage as well. And the other thing that people should know is if you are ever in an emergency, don't hesitate to call 911 to get them there. That does not mean you have to go to the hospital. Just because you've called 911 here does not mean you are legally required to go with them to the hospital. And if things do take a turn and you haven't called 911, we've now wasted a period of time when we could have had medical professionals on the way. There's been a lot of times where we do ride-alongs with ambulances and stuff. You'll assess the situation, you'll say, hey, for them, they were like, we're paramedics, and so we can tell you this, this, and this. The option is available to go to the hospital if you want, but we've given you this information now that we've said it. So I would say, one, make sure that they take a second, because a lot of our first reaction is to spring up and get up. And if you have a neck injury, you don't want to do that. So, hey, stay down, take inventory, have them take inventory. If there's any worrying or concerning symptoms, you can always call 911 and then reassess. But again, I would be listening to that person, because as a not medical professional, it's going to be really hard for you to tell outside of glaringly obvious. They're altered, they're not making sense, they're unconscious for a prolonged period of time, they're vomiting their guts out, or they are saying, I can't move or feel my arms. Those are kind of the big, definitely don't move. Don't try and move them. If there's other people going, they move. The patient doesn't move.
Yeah.
But it's one of the things where neck injuries are nothing to play with, because it's so close between what is a bad neck injury that is fine, that you just need to rest out PT, and what is a bad neck injury that needs a lot of intervention. And it's something that would be really hard for a lot of non-professionals to delineate.
Yeah. So kind of like stepping out of the emergency medicine context a little bit. So maybe you even had an emergency medicine visit, and you've like ruled out broken bones and stuff like this, and you suspect some kind of like soft tissue injury, muscle, tendon, ligament, something like that, and you're like interested in getting an MRI.
Yeah.
But like, what tips would you have in order to who should you be talking to? How do you approach getting that MRI? How do you interpret results?
Yeah,
things like that.
For sure. So again, stepping into the emergency context just for a second, if you come in for that and it's a soft tissue, unfortunately, most of the time, everywhere that I've heard of, you're not getting an MRI in the ER. That's just not going to happen because it's not an immediate threat to life or limb. We will get an X-ray in a hopes to expedite your MRI in the future, because a lot of times insurances will require a X-ray before you can get an MRI. Unfortunately, sometimes insurances do say you need to do 2 weeks of PT and you need to show that everything else has failed and you need prior authorization and blah, 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 blah. So if you have good insurance and you haven't had an issue with that, I would definitely suggest following up with your primary care doctor, going through the steps and getting the MRI, because one of the interesting things about MRIs is a lot of times the full extent of the damage and the full diagnostic ability won't show up for a few days, like 48 to 72 hours. When you first hurt something, there's all that kind of trauma, swelling can kind of obscure certain findings. But if you give it some time to kind of settle in, you're not losing any kind of recovery time. You're not losing anything in getting better. You're really helping the imaging doctors, the radiologists, see what's going on better. That being said, some of us don't have insurance. Some of us have not great insurance, and some of us have insurance that tries to just put us through the ringer and run us around circles. So there is always the option for cash pay MRIs. And sometimes, I know for the last insurance I had, cash pay MRIs was cheaper than my copay on my insurance MRIs. Sometimes people don't want their names attached to the MRIs, or they don't want it on their medical record as much, or they're for some reason don't want to be going through insurance or official means like that. Cash pay MRIs are getting more and more reasonable. Like the ones that I've seen in Vegas recently, and just looking a few weeks ago recently, they're between kind of $300 and $500 on the cash pay for a single thing. And most of the time they'll say with contrast, without contrast. Most of the time, if you're just looking at musculature and tendons, you don't need contrast. Contrast is mostly looking at blood vessels, bleeding, smaller specifics like that.
Wrists.
Even with wrists, a lot of times you can get a lot of stuff without contrast. Again, like if people are getting it with contrast, like orthopedic surgeons are definitely the experts on this. But I would say a lot of the stuff you can get by without having to do full contrast. And with that, a lot of these cash pay places, some of them, I'm not sure if everyone in America, some of them you might still need a referral from a physician. But I know there's places in Henderson, there's places in Vegas proper that you don't need a referral. You can just call them straight up and be like, I would like to purchase an MRI of my shoulder. I would like to purchase an MRI of my elbow. And they say, cool, credit card information. And then they have a doctor that's doing all of those. The biggest thing I would warn, if you are going for a cash pay MRI or you are not going specifically through a physician at first, is have a medical professional ready. Because when you get that read, you might be finding some things that you have no idea what to do with. One of the biggest things that we find in medicine a lot on imaging is called incidentals. And incidentals just means it's something that I see that is not baseline. It's not what I would find in normal anatomy, but it's not that abnormal.
Yeah.
Or it's not even that abnormal, because it's like, I can't count the amount of times I've gotten a CT of people's abdomens and there's a cyst on the kidneys. And they're like, oh my gosh, it's cancer. I was like, probably not. But I have to tell you it's this, because if you do get cancer later or something does happen, like we were seeing stuff like this, is this early signs, most of the time very benign. A lot of times you just get an ultrasound to see lung nodules, I see all the time. But even you might see a little pieces off of bones or little changes in the joint architecture. And some of those are acute, meaning they just happened. Some of them are chronic, meaning they've been there for a long time. And some of them you're born with. Some of them happened like very, very early in development. And so the radiologist is not going to, the imaging doctor is not going to be the one to tell you that. So having a primary care doctor ready, orthopedic appointment ready, someone to be able to talk to about this. Because if you Google these things, you're going to give yourself a heart attack, because a lot of the things will sound similar and bad, or a lot of times certain findings are bad in certain contexts, you have to take the clinical picture of what the patient, what the person looks like, what their complaints are, and then what the radiology findings are.
Yeah.
There's so many times where I would get like a image of a chest or something like this, and I would know the patient is a smoker. And they're like, oh my gosh, I'm so concerned with all of this. I was like, I'm looking for pneumonia, yes or no? No, I know this person's been smoking for 45 years. I don't care about this. But when it comes to joints, like you could know, yeah, it's hurting specifically here, and we're asking a specific question, like, is this your teres? Is this your infraspinatus? Is this? And then it's reading all this stuff about your joint capsule, and it's reading all this stuff about bursa, and it's reading all this stuff about things that's not related to any of your symptoms. And a physician can tell you, well, this might be a problem down the line, but this doesn't go with your clinical picture, is what we say. So I would definitely have someone on the outpatient basis, meaning an office visit, ready for that. If you bring the discs into the ER or into the urgent cares, we're probably not going to look at it, to be frankly honest, because we frankly don't have time a lot of the time. If there's a huge problem, like if you're like, it says grade 4 tear and I can't move my arm anymore, please for the love of God, come in. Please for the love of God, bring the disc. Because we might not be able to do anything right now, but we can try and get you connected with the right people.
Right. And those places exist for triage and
correct. And to get you to the areas where you need to go and to try and expedite those things. But a lot of times I would tell people, don't expect to come to the ER to get the finalized treatment. Right. You're going to be sent somewhere else all the time. I say everyone has to follow up with their primary care doctor. But having those expectations will help you from being very disappointed when you go to the ER or an urgent care. But I do want people to know that that is an option to cash pay for these things, because I do know medical care is slow and medical care is expensive. So having those options available. And even if the option to look over the stuff or follow up with the stuff is a telehealth visit, you might not be able to get in with a primary care doctor in the office on a reasonable basis. They might be telling you 6 weeks, 7 weeks. A lot of insurances will cover telehealth, and a lot of telehealth is pretty affordable of just, I need to make an appointment. They'll contact you via a Zoom call or something like that, and you can explain what's going on, and they can at least get the ball rolling. Again, I always say for physical exam, for musculoskeletal stuff, I would prefer people be there in person so people can poke it, touch it, move it, twist it, pop it. Hopefully not. But all of those things. In person, it's a lot easier. But again, if you need options and you need something, telehealth is not the worst.
For sure. And then to just kind of continue our de-escalation of severity. So say I don't have anything acute going on right now, but I want to be engaged in the medical system as some way. Just as an athlete and an acrobat, like what considerations should I have, and why should I even go to the doctor to begin with?
Yeah, no, exactly. Because acrobats and circus people are still human beings and stuff still happens to them. So one of the biggest things I say is if you're following up with someone, I always recommend if you can have a primary care doctor, because they're kind of like the conductor of the symphony that is your medical care. They're the ones to establish baselines. So a lot of the times you'll be like, man, I've been going to see my primary care doctor and all my labs are always all black, which means they're all fine because they're not red and having exclamation marks next to them. I don't know what I'm doing. But the issue comes when you personally might have a certain lab value that just is abnormal. One of the most common ones I see is in female acrobats or female people in general is anemia, or kind of a low blood count, a hemoglobin. And so anyone with a uterus and of childbearing age is at risk for having a low blood count. And that might just be baseline for them. Should they take iron supplements? Probably, because they should probably try and get that baseline up. But if you've been having anemia your whole life or since age early teens, and now you're starting to get really fatigued, now you're starting to get really exhausted, a little bit lightheaded when you stand up, and you come in and I see your hemoglobin's low, and I'm like, oh, this is clearly your anemia. This is clearly, we need to get you on iron supplements. This explains everything. But if I have those baselines, because you've been seeing someone regularly and we have laboratory studies, I can say, wait, your blood level's always been like this, and now you're symptomatic. Now you're having symptoms. I don't think it's just your blood level. Something else is going on. We need to look. Are you a little dehydrated? Is your thyroid okay? Now I need to do a little more investigation. So having a baseline is important. It also makes it easier to have a medical home to be able to, when something does acute happen, call. They'll normally have a nurse hotline, be like, no, we can fit you in, or hey, go to the ER, or hey, I think we can get you like patched with a specialist or something like that. This isn't just for primary care doctors and everything like that. People have massage therapists, people have physical therapists, people have athletic trainers. And a lot of times for a lot of acrobatics and performers and people that I see, we'll see those people way more frequently because those people will a lot of times look at the musculoskeletal a little bit more or with a little bit more focus.
And certainly more frequency.
And more frequency, yeah. Exactly. I know we're super lucky to have athletic trainers like in-house at Circus Center. So you can just we'll go online, make an appointment and see them, but you can kind of follow up regularly. The important thing still is these are people to follow up with you over the long run. So following up with them regularly to give them updates helps them keep track with what might be wrong if something goes wrong in the future. If all you said is, hey, yeah, I'm a base and I do hand-to-hand, and then you do a few exercises, never see him again, you start cross-training some trapeze, you start doing some straps, and then you go in and be like, well, now I'm all of a sudden having these problems. And your athletic trainer, your physical therapist, your massage therapist is like, well, this is weird. Like all your muscle imbalance is different now. Things are off, and what the hell happened? And if you're like, oh, well, now I'm cross-training this, and this. Well, that then gives them another shift that they have to start thinking differently. And one of the things that's a shock to some people, but I don't know why, is medical professionals, all of the above, don't magically know the answer when you tell us inputs. Like we have to think about it, and like we sit and we're like, okay, like how would that be? Like how would it be this? Like I'll close my eyes sometimes and try and like visualize the body and how things move. And so the more I know in advance, if I know, because you came and saw me when you said you were going to start training straps, and you saw me when you said you were going to start doing trapeze, and now you say my shoulder's hurting. I already have all of that in my processed in my head, and now I'm like, okay, boom, 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 boom. I'm going to check these things and let's get going. It's faster, it's more efficient, and it's less stress on the medical professional. The other thing is prevention, because if someone is a hand balancer and tells me they're going to start training straps, I immediately am thinking of, okay, well, what muscles are we using in hand balancing? What muscles are we going to be using in straps? What's probably weak on them? So it's probably this. They're probably going to progress very quickly through the basics and start doing some more difficult things. So I'm worried about here, and here.
Yeah.
And can tell you that ahead of time and be like, hey, watch out for this, and this. Or, hey, I would make sure that you're cross-training these two things. We're really leaving out this key muscle group that can cause a big imbalance. So the importance is more than just what you are getting out of that appointment right then. It is setting you up for future success if things are to happen in the future.
Yeah, and I think that brings up a great point too of just like, cross-training is great, but coming into it with like an athletic background, you're going to progress faster. But you do have these micro imbalances, or the activities that you're doing might have like specific demands. So like, things like rings or straps might have like a lot of demands on like the biceps tendon and the pec tendon that you might not really get in other contexts. And if you're like super strong, you're progressing really fast, but like your tendons are much slower to adapt, as we discussed earlier.
Yeah. And it's one of the big things that I think that's why it is really important to have good coaching, or having a person that knows that discipline really well helping you out, because they'll know exactly what muscles need to be activated, what good form is, bad form is, all of this stuff, and help give you the best chance as you're progressing to avoid injury or maintain a good progression level. So really having a good coach or a good mentor, someone that can help you know that progression. But the other thing is just realizing that you are an extremely talented individual and you are well above like the 90th percentile of athleticism in the US. So things are going to progress a little different than a Joe Smo or someone who hasn't done anything doing these acrobatics or these demands, and keeping close tabs on changes that you feel in your body, any new pains, any new things, and just being aware of those and knowing that you're using very different muscles. Even if you're very, very strong in one certain way, you might not be as strong in another certain way. And you might need new conditioning. You might need new stretching now because these muscles are developing and all of a sudden I can't quite get to the position I was.
Right.
And you might think you are, but the difference between kind of scapular engagement versus scapular engagement can be minor and you don't notice it, but make a big change down the line. And that's where kind of imbalances can come in and cause havoc on everything you do.
Yeah, not like particularly things like shoulders where you have like all of these muscles and like suddenly you're putting more demand on one. You can like have a very much like a local bottleneck of like, hey, there's this muscle that like you are going from 0 to 100 and it just takes time to adapt. And
it's even distal, it's even far away body things. Cause it's like I had a problem with my shoulder that I thought was from a trapeze injury, which probably was aggravated by it. But I went and saw one of my mentors, Dr. Alt, who's a DO and does osteopathic medical manipulation, basically chiropractic on steroids. That's really, really effective, and I recommend if anyone has a problem. But he looked at how I was walking and just asked me, well, when did you break your foot? And I said, what the heck are you talking about? He's like, well, I can see your right foot is turned in a little bit, which is putting pressure on your tib fib, which is turning your knee this way, which is turning your femur, which is turning your hip and dropping this, which is stretching this muscle, boom, all the way up to this. And I said, well, I broke my foot in high school. And he's like, wear a shoe insert, see what happens. A few weeks later, shoulder pain got a lot better and just everything kind of straightened out a little bit. So even as we start cross-training seemingly very different disciplines, if it's causing any imbalances or causing any far away problems, it can start wreaking havoc or causing changes very far away from that area.
Yeah. So in terms of just like having that like physical baseline, like do you have like recommendations for just some kind of like general strength and conditioning program, like basic human movement patterns, having this kind of like overall strength, as well as like, specific to whatever discipline that you're going?
So there are probably some general ones that work okay. Yeah. The problem is what we do is so specialized and so a high level that it's like, I would even take pause when it's within a discipline of like a base. And it's like, well, how do you base? And it's how is your body height compared to your flyer's body height? Are you guys the same weight and you're holding each other up? Is one significantly lighter? Is one taller? Like there's so many permutations, and it also depends on how you yourself use technique. And one of the problems that I see in circus, acrobatics, and performance a lot is we don't have any real research.
Yeah.
We have some people that are doing great work, and we're getting a lot more recently. We have some amazing, like I'm sure people have heard of like Emily Sherb and Jen Crane and Stephanie Greenspan, and people are putting out these amazing, amazing studies. They're all very new. It's relatively recent that we're getting these things. So guidelines about like, well, what exact engagement are you having? And does everyone have this engagement when you're doing this? You look at how many different, I do trapeze. You look at how many different ways that people break or kind of sweep back before their skill. Everyone does it different.
Yeah.
Because I'm short. Some of my co-flyers are tall. I don't have a flexible back. Some of them do. My legs are more flexible. So there's so many different aspects that would go into a how do you condition.
Yeah.
The biggest general recommendations I can make is that strength is not everything and flexibility is important, and making sure that it is active flexibility you have. Because one of the biggest things I'll see people just go into a stretch and just like flop and just like, I'm just going and holding this or pulling myself down. Being able to be in your end range of motion, meaning as far as a muscle will go, and being able to flex it, being able to have support there is important. And making sure that you are not kind of ignoring the flexibility component of this is going to help avoid a lot of injuries. What a lot of people do sometimes, I myself am guilty of this sometimes, is you'll use a lack of flexibility or a lack of range of motion to kind of know where your stopping point is.
Yeah.
Just be like, I just go as far as I can, and then I'm not flexible enough to go further, so I know this is where I'm going to go. And so people have some problems of they'll gain flexibility and then be like, I don't know where to stop anymore.
Right.
My timing's all off now. But just like a fine race car, you want at those higher levels, you want that fine control. You want to be able to finely tune, where am I locked in? Where am I pushing? And so the most general things I can give is making sure, one, that not only your strength is good, but your range of motion is good and your strength at end range of motion is good. When it comes to specific muscle groups or balancing and everything like that, that's going to have to be a lot more case by case basis, because everyone uses a very micro different strength and muscles and engagement and body positions and everything like that. We might get to the point where we have a lot of data down the line with all these people doing amazing research and figuring out this is actually the most ergonomic way to do this. And then we can start having some conversations about, okay, this is the most ergonomic way to do this. So these muscles have to be engaged. These would be in balance. Make sure you're training these. But at this point, I think it would be really hard to say that. And we might not even get to the point, because we might say, hey, there is no best way because it's going to depend on so many variables. So that's where I say it's really up in the air for specifics. But that's where not only your medical professionals, like your massage therapists, your PTs, your ATs, coaches, come in handy a lot. If you're really new to something and you really are learning the basics, having the good coach, having the baseline knowledge is so key to make sure that you're not doing the things that at least we know is wrong. That we're not like, oh, we're in a danger zone of we're crunching all of this and putting a lot of pressure of like an arched axial skeleton and crushing our vertebra. Because if you're learning on your own, when you see the professionals, when you see the people that are really good at stuff, they're intentionally breaking the rules because they can do it controlled.
Right.
If you're new to something or you're learning something or it's a new skill and you're watching everyone, yeah, it can be a really good place to start, get ideas and start playing with things. But having a professional there or someone that knows this really well to help you be like, yeah, no, I made this mistake before. You're going to think this is easier, but you want to do this instead.
Right.
Is key in injury prevention along with everyone else in the health field.
Yeah, no, those are great points. You've been kind of hinting at like a lot of the research that's ongoing, and I know that you've been involved with this kind of like circus meets medicine concept. Could you like maybe share a little bit more about the motivation and what you've been doing with that?
Yeah, so I've been working with one of my colleagues, Scott McDonald, who's I was going to say famous trampoler, but I guess it's trampoler and tumbling and hand balancing and juggling and everything else that he does. But we started this like 3 years ago, 2-3 years ago or so, because I did not let on that I was a doctor the first time I was in the gym and was just listening. And we were just having conversation about the lack of educated medical care of physicians, massage therapists, physical therapists that really understand the demands on performers and the demands on circus acrobats, because a lot of times it can be kind of compared to sports, but it's not really the same. There's not necessarily a rule book you're following. There's aesthetic components to it. There's a monetary job component to it.
Right.
And there's a lot of demands that just aren't really appreciated. And then I had just been looking in literature, and there was a really lack of any physician data. There's really good data out there, and I am so grateful for all the people doing the research. But the other problem was the research just wasn't getting out there sometimes. There would be great studies and no one would hear about them. So me and Scott a few years ago tried to start making a Circus Meets Medicine conference, which was not only for physicians and medical professionals to come and learn about important issues. Last year, our entire beginning was about the importance of women's health. And so I started by saying, I am neither a woman nor an OBGYN. Now let me give the stage to some women in OBGYN to talk about issues of like bladder incontinence on trampolines, pregnancy, like menopause, even as people are doing stuff later, peri-pregnancy, after you did a C-section, how long before you can start doing handstands and inverting and stuff. There's not much data. And so we tried to get some professionals to come and start working with us and presenting this kind of expert opinion at this point in time. But the other kind of goal of this is we are kind of allying more and more with UNLV, the local university, is to get research out there, get some data behind it, because we have a lot of facts and stuff that we know about circus colloquially.
Right.
But when you're trying to make big policy changes, or you're trying to get insurance to uncover things faster, or you're trying to get the White House to recognize circus under the National Endowment of the Arts, you're trying to do any of these things, they're going to ask you, where's the data? And so that involves kind of the bigger things of where are people getting care? Do people have a lack of care? What types of injuries are happening? What types of injuries are happening per apparatus? That's really important. But so is the baseline data of what muscles are engaged as we're like this. Let's put electrodes all over your arm and see relative muscle engagement. Let's get people on steer wheel and ask them, what handed are you? What direction are you spinning? And do you get dizzy? Have you ever gotten dizzy? When did you stop getting dizzy?
Yeah.
And again, we don't have special devices for this, so we're trying to make this stuff. We're trying to find mouth guards to put in people's mouth to check head acceleration or head movement of that. We're trying to get industrial meat hook things, weight things, but hooking that up and then putting our hair hangers under it, because you'll say, hey, I'm hanging with my body weight. And it's like, well, guess what? You're hanging with more than your body weight because the winch is going up and pulling you up.
Yeah.
Or looking at one of the things that we just have a lack of ability to measure, but like, is there ability to put like a pressure plate on the hand in between people doing hand to hand to see where is the movement? Is it straight down? How is it alternating? Spotless motion capture. All of these things are just a fertile field of data to put out there so that people can understand this more. And so that's been one of the big things that we've been trying to do, is not only educate the medical professionals and bringing circus people and performers in to hear that conversation and give their side of the story. That's like, yeah, I understand that you guys are trying to do this, but this is how I felt when this happened. Or this is how I feel when you tell me this. That's just as important. But then also on the other side is getting the research and getting those numbers out there to be like, hey, this is what's actually happening. This is the actual raw data. And right now you look at running and you can see like 50 million different shoe inserts and like every way people do it and like diameter of toe box and stuff like that. We have all this data out here. You try and look at anything for circus and you can find a few papers. So really trying to get more baseline data out there so we can make those bigger studies, so we can figure out how to do more preventative stuff. Because I'm surprised every day of like, I'll see straps artists that will come with ankle injuries, or I'll see hand-to-hand people and they'll have like ribs that are slightly off.
Yeah.
And it's like not something you would think of, but then I'm like, now that I think of it, you are kind of tilted this way. Oh, I guess that makes sense. But if you just asked me in a box, I would not know that. And so I think there is a real importance of getting stone cold data out there. And that's why we're two people right now, but UNLV is hopefully working with us. We've been in talks. We've got approved to make a UNLV Institute of Arts and Medicine, trying to get more disciplines together, trying to get engineering in, trying to get medicine in, trying to get policy in of how many people come here on visas, and what is that process? How can we make skilled workers visas easier for people? And trying to get kind of the humanities in there. I have a good friend of mine that spoke last year at Circus Meets Medicine, Dr. Isaiah Lin, who's a philosopher, looking at how aesthetics is important for the well-being of society, and how like all these important things we do when we create shows, when we create choreography, we're creating like de novo, like out of nothing, something with value. And the philosophers can talk more about that and the importance on a societal value, and why should the NEA make more grants for us for Circus? Why should the Nevada Arts Council support more small productions and stuff like that? So that's really, it's Circus Meets Medicine, or Institute of Arts and Medicine, but it's really more than that, of just trying to elevate everything that the circus community, performers in general, there's pole studios, there's silk studios, there's so many people that fit under this umbrella, that are part of the family, even if they feel like they wouldn't identify them as a circus individual. Like, I just do this for fun. It's like, no, you are part of the family. You are part of this, and we're just trying to elevate everyone up through helping people take better care of you, understanding what you do better so we can take better care of you, and understanding what you do better so that you can do more cool stuff. Because if I make what you do easier, you can do cooler things, and that looks really cool and increases the aesthetics and increases the art form and increases everything that's going on. And I think that's just a win for everyone.
Yeah, no, absolutely. And just like as an observer, like looking at the sport of gymnastics over the last 50 years or whatever, if you look like women were doing uneven bars from like then to now is just mind blowing. And in all these other sports like baseball, they have like the motion tracking, pitch design labs, high speed cameras, and things like that. And even disciplines like music, they've been doing a lot of kind of research on what's happening to the shoulder over time, dance and things like that. And I think that circus is in a lot of ways like way more dynamic than all of those, because you're asking like more of your body, but the money in research traditionally hasn't been there. And specifically in the world of acro, like sports acrobatics has existed for a reasonably long time. There's literally like hieroglyphics of like ancient Egyptians, like tumbling and doing partner acrobatics and things like that. But there's been this kind of like surge in popularity in the last 15, 20 years. It's really been driven by like acro yoga and this kind of yoga community. And really one of the main missions of this channel is to try and bring more of a scientific and evidence-based approach, and really support people who are really pushing that forward. Absolutely. So could not be more happy to have you on the channel, and absolutely really appreciate all the work that you're doing. If there's anything that people can do in order to support the Circus Meets Medicine, or your work in general, or if they want to follow you, we'll have links to your social media and stuff in the description. But like, if there's anything you want to share with people. Yeah, I mean, the biggest thing I can say is the movement forward in gaining research and gaining the ability to do more and more with this is going to come from the community. It's not going to come from the ivory tower of researchers being like, I have this great idea about this thing I've only thought about. It's going to come from people that have experienced something and being like, this is a weird thing that happened and I don't know why it happened, or I have an idea of why this can be better, or why this is not as good of a way to do it. And so if anyone has any research ideas or things that they're interested about, feel free to DM me, message me, send me an email, whatever, get in contact, because these are the things that are really going to move stuff forward, of questions coming from within the community being answered, and trying to figure out ways that we can make this stuff better and figure out how to move that line forward. The other thing is, if anyone is interested, we always try and put Circus Meets Medicine on YouTube. Literally, if you type in Circus Meets Medicine, I think it's just last year's that is on right now, but it's in 3 different parts of kind of short lectures in the beginning, longer lectures in the middle. And what we always do is we always have a section at the end, which is performers coming in and giving a no lights, no costume, no music performance, and explaining what they did and why they feel. I know we've all had a bunch of times where you do the hardest skill ever and then no one says anything, and then you spin really fast and everyone claps really fast, and you're like, that was the easiest part of my whole routine. Thank you for clapping at that, I guess. But being able to explain that stuff
you definitely have an opportunity to watch that on YouTube if you're interested at all. And we don't have a date yet for 2025, but we're going to be doing it again. So if anyone in Las Vegas would like to come, you are more than welcome to come and sit in that conversation. But I think the biggest thing is kind of asking those questions, forwarding the knowledge we have about this, because it's gonna come from grassroots up. It's not gonna be science. Researchers and universities are there to help us move it forward. No one's coming in as a golden knight to save us. No one's coming in as a golden knight to do all of this for us. It's getting resources to us to lift our own art form up. And so that's going to take some community involvement, some community bringing that all together.
Yeah, amazing. We'll have links to Circus Meets Medicine YouTube below. Thanks again for coming on the channel.
Thank you so much.
And yeah, see everyone next time. If you want to see more of Nathan, let us know in the comments and we might be able to make that happen.
For sure.